Hi guys, we start again today with Wednesday's lesson of the day. I missed last week because I got murdered at work. 16-hour workdays sometimes, very often. I'm trying to stop it. And we went to Coachella. So I did a quick Wednesday, Wednesday enactment as Ben the emo. I was in full emo character. We had to erase that just because already a couple of patients questioned my seriousness and how serious I am as a surgeon. So decided to be a little more professional and just delete that for once in my life. And hello to everybody. Thanks for saying hi. I did go to Coachella. It was a total shit show. And I went to Coachella the first year, I think, and we used to park in parking lots, like on the dirt, and sleep in the car overnight and go to the festival before we even knew what Coachella was. And it was the coolest thing. And this year was a bit rough, bit of a shit show, so we left a day early and headed back. But I did do my little emo interview because I had to sit there waiting for Ana Guanche, and I started playing with my hair in different ways. And sorry, the video is down and it's gone. But it was the real other me. But today, speaking of hair, saw a lot of patients in the office, saw about 50 people today, and I do apologize to everybody who waited. It is not my intention. There's just so many people to see, and I try to go as fast as I can. And some people do ask more questions and talk a lot, and I always sit there and wait and answer everything. And then still people leave and say he didn't spend enough time with me. I felt like he rushed out, and it's because I talk fast. It's not because I leave the office without waiting for them to finish. So either way, the lesson of today was brought upon by people taking hormones. And I started thinking to myself, what the hell is going on here? What is this trend where everyone's taking hormones? And it's mainly about hair loss, which is why they see me and they have all these other weird things going on. So I'll go over just hair loss in general and the types that we treat, and then the hormones. And why is my sister saying, I told you? So whatever, I'll tell you. So I have these guys coming in the office and they say, I don't know what's going on. I'm 40-something years old and I just started losing hair. And they live in LA and they look like, reasonably fit. And I ask, did you start taking HGH or testosterone? And they say, yes, I did. And they tell me, and I say, well, who prescribed this to you? Was it an endocrinologist or was it a quack? And they say, what do you mean? It was my doctor. I'm like, was it an endocrinologist or was it a quack? And they say, well, it was my doctor. And I said, is your doctor a board certified endocrinologist? And they said, no. And I'm like, so why would you let another doctor prescribe you human growth hormone, testosterone, and all this stuff? I go, it's hard enough for anybody to control their regular hormonal changes as they go through life. Why would you let someone who's not board certified mess with it when the board certified guys can't even do it for most patients within 3 months? It's very, very difficult. So in this case, the patient started taking testosterone, human growth hormone, and felt better, but started losing hair. The problem with this is the hair loss was a surprise to him. He wasn't notified about this. Goes back to the clinic, says, what do I do? They give him finasteride and dutasteride. So these are 5-alpha reductase inhibitors, which means they block the conversion of testosterone to DHT, which means the doctor is giving them testosterone as a supplement and then blocks the testosterone. Okay, I hope everyone's confused by this. They give them testosterone and then block the testosterone. Now, an endocrinologist would not do this because they're trained. A quack might do this. So there is this world now where people are prescribing hormones routinely because they tell you that your testosterone is low, according to what I don't understand. And these people are getting hair loss. Now, what else is happening is they may also be getting accelerated progression of cardiovascular disease. We don't know. Andre the Giant had something called gigantism, which means he had too much human growth hormone. And that is what killed him early because he naturally had it from birth and he ended up getting really thick joints and his heart got thicker and heart attacks happened and that kind of stuff. So now they're giving it to people like candy, telling them it's healthy to have more testosterone because it makes you feel good because your testosterone is low. Either way, I would advise caution letting anybody prescribe you something that'll change your hormones unless they're an endocrinologist. So I would see an endocrinologist and ask them, and if they agree, totally, go take testosterone. And there are people who have low testosterone and HGH, and there are people who need it, but the majority of people who are taking it do not need it, and it causes these problems like hair loss. So the hair loss discussion, what do you do for these patients who are on it? They're pretty much helpless because they have testosterone attacking their hair, which we call it androgenetic or androgenic hair loss, which means your testosterone makes your hair follicles more susceptible to falling out by going into the fallout phase more frequent than the growth phase. And this is something that when it happens in a sequence in your hair over 3 months to a year, you tilt towards the fallout phase of hair rather than the growth phase, and you start to lose hair in general, lower density, thinner hair follicles, and so on. So you can do PRP to try to make it better, which is platelet-rich plasma, but likely it won't help. So most people who get hair loss, like me, I've had 2 hair transplants, get it because of what we call androgenic alopecia, which means genetically we're screwed. So my dad, he kind of fucked me. So this is from a familial trait. We don't know if it's from the mother or father, to be fair. It's from both. It's a mixed gene. And you get hair loss because your body's testosterone, for most people, tilts you in the direction of fallout. At some people, for me, it started at like 19 years of age. This can happen in women too. It is less common, however. So women who have problems with endometriosis and other hormonal problems around the uterus, ovaries, and endometrium can have that type of issue as well. However, it's much less common. When we have androgenic hair loss, your options at a young age are to take Propecia, finasteride. Finasteride is the one clinically proven medication that you can take, which fortunately we found out about through treating prostate enlargement, where you would use Proscar, a prostate enlargement pill, which is also finasteride to shrink your prostate, but these people would start having hair grow back. And so they did their clinical trials and realized that you could take 1 milligram instead of 5, and you'd get a clinical improvement in hair loss. Less than that wasn't so effective. And for people who could tolerate it, usually what happens is it slows or stops their hair growth, and then some people get regrowth of hair that was lost. The problem is that not everybody can tolerate it because it lowers their workout energy, their sexual energy, and their body just doesn't have a reserve, so they have to stop it. Other patients do fine with it. I took it for years and I did fine, and it doesn't really have any known long-term negative effects that we really worry about, except for if you're trying to get someone pregnant. It decreases your sperm count and your sperm fluid levels during the time that you're taking it. So you do want to come off of it if you're trying to get someone pregnant or accidentally pregnant. Finasteride for women is another option. However, it is only in a select set of women. Finasteride does not work on all women. It's for people who do have higher testosterone, again, because their androgen balance is off, and so they can actually use that just like they would use spironolactone for skin issues. They can use finasteride to calm down hormonal imbalance in general. So some women can take finasteride, not all though. This is like uncommon, and again, the endocrinologist would be the one prescribing that. Dutasteride is another one that's a mixed reductase inhibitor, and is okay for people who can't tolerate finasteride but have no other choice and really want to take it. So dutasteride is the other one, Avodart, that people take. Beyond that, for hair loss prevention, we have PRP, and PRP, which is platelet-rich plasma. If you do it according to the research studies, you have to do it once a month for 3 months, and then 3 months, 3 months, 3 months. And the reason you have to do it so much is because they weren't using real PRP. Someone who draws your blood and takes 10 milliliters of blood, it takes out 5 of it and calls it PRP, is probably also a quack. That's not PRP. It's plasma, not platelet-rich plasma. Platelet-rich plasma is generally considered somewhere around a 10% yield, which means you would take 120 milliliters of blood and spin that down to 12, which is a 10% yield. And regardless of the platelet count, the concentration is what really matters. That you inject it into the scalp and you get an equal effect from doing one treatment. So you can do it with one treatment, with some microneedling, try to be as atraumatic as possible so you don't cause traumatic hair loss from it. And we've had a very high success rate. Now, to make it super successful, we added in other things. One of the other mediums we added in was nanofat. Nanofat is a solution of progenitor cells that you get from withdrawing the fat from your abdomen, turning it into a liquid, and injecting that along with the PRP, and now you have nanofat PRP. And if you mix that with whole fat for the base of the scalp, we call that PHAT, fat. Pretty hot and tempting. It's actually platelet hybridized adipose therapy. So we've, with this, had a super high success rate where about 90% of patients come back and tell us that they have had their hair loss slow down or stop, and 30% of patients would see a visible regrowth of hair if you were to look at a photo. Now, this does not work for everybody. There are patients who it's contraindicated in. You cannot do microneedling PRP stimulation in somebody who has alopecia areata. Alopecia areata or alopecia totalis are issues where your immune system attacks your hair, just like patients with vitiligo. If you've seen patients with vitiligo who have regular toned skin on most of the face, but then patches of white, big patches I'm talking about, not little fungal ones, big patches, that's called vitiligo. Alopecia areata is a similar thing where the immune system goes and it attacks your hair follicles, and your hair follicles can fall out in satellites, in circles. With alopecia areata or alopecia totalis, what happens when you put PRP into those areas is you stimulate the immune system even more, potentially. Doesn't happen on everybody, but you have that risk. So you have to tell these patients, PRP might not be an option for you. I might inject you with PRP and it might make you worse. Most people, when they hear that, they say, no. I don't want to do it, even if my chance is 50%, because 50% is pretty high. So not a good option for people with alopecia areata, neither is microneedling. The other option that we add to this, which I was getting at, was either exosomes or stem cells. Exosomes and stem cells are other types of bone marrow derived products or weird stuff that people sell, and they can mix them in, and exosomes seem to have not equal efficacy to nanofat, but better than A-cell, which was the other thing that we were using. A-cell is really nice. It's a powder taken from pig bladder, so it's an interesting place to get it, but it's a powder that we mix in with the PRP, and it makes PRP work a little bit better than exosome, than nanofat PRP. So nanofat PRP with fat and platelet pore plasma is what we call fat procedure, PHAT, and that works fantastic. Then we have nutritional supplements. The ones that we use are based on biotin and biotin cocktails. The best one in my experience is Nutrafol, Nutarfol, and there's men's and women's, and they have a cocktail of little stuff in there that works a little bit better. It does not stop hair loss, but it helps hair grow faster and healthier. So like you've heard people say like, oh, her hair was like a horse's mane. It's like that. So the hair is like healthier, thicker, bolder, and it looks nicer. So we love Nutrafol for that. Viviscal is the other one that's very popular. I don't know why they have a doctor's version and a patient's version. It makes no sense to me except for like marketing, but Nutrafol is available everywhere and it's really, really nice. The next step in this kind of stuff becomes hair transplantation. Hair transplantation, there are different ways to do it. There's FUE, which is follicular unit extraction, and FUT, which is the transplant, where you actually go cut out a strip of hair. Now, the kind that I had was extraction. Extraction means you shave the sides and the back short, you pluck out hairs one by one, and then you pop them into the top. Versus the old way we used to do it was flaps of skin that you pull over, or punch grafts, which are bigger grafts that you put in because we thought the skin needed to survive. We realized, no, you just got to take the follicular unit, which is anywhere from 1 to 4 hairs, and you can actually pluck those out and then put them back in, and it works fantastic. Those hairs are a little bit finer than the FUT, which is the strip technique where you cut out a strip of hair and then you can get units out of that. The reason they're finer is because you can get them from here, from there, and you can pick the finer hairs which occur on the bottom of the scalp there, and you can put them on the frontal hairline where you want finer hairs. If you put coarse hairs on the frontal hairline, it looks like pubic hair, and it looks thick, it doesn't look like it sits so well, and you can't do this temporal region so well because the skin is different. This isn't scalp, this is temporal skin. This is scalp skin, it's thick. So over here you can graft easily, here you can graft easily, here you can't graft so well because it's thin and it looks like pubic hair there. So the thinner hairs are better, and you can actually even grab nape hairs. Nape is, so if you go back to the scalp stops at the occiput, which is that bone. Below that is your nape, which is your neck hairs, posterior neck hairs. Those you can take a couple without making it look patchy, and those are also great for eyebrow transplants when people do them. They're the finer hairs. Strip technique is the other technique where you actually grab the strip of hair out, take the follicles out of there and implant them. That is better for if you want more hairs, or if you're doing here and behind, because you can get more hairs out of that than you can with anything else. You can also combine the techniques, and it works fine that way too. So the most effective way for me for frontal hairlines is FUE, but for bigger hair procedures, you need the FUT, the strip, or you have to do 2 FUE procedures, which is fine. Cloning is the next frontier, where we hope, everyone says it's 5 years away. They've been saying this for 15 years, so that I've heard of. They always say it's 5 years away, it's 5 years away, it's 5 years away, and then Korea is always like, we have it, and Korea, can't believe Korea sometimes. So great surgeons there, but you can't believe everything you see on the videos that they put out. So it's always 5 years away, and unfortunately, it hasn't happened yet. So cloning would be incredible. The idea of cloning is you take someone's hair out and you can replicate it and then implant that. The problem with this is, how do you get something to grow from nothing and then stop it from growing more, which is what we call cancer. So we gotta figure that out, how it can replicate, how it can survive, and how it will stop growing when you want it to. So that's the trouble with cloning, and who knows when we're gonna figure that out. For women, it's a little more complex. So women, I always advise, they go through a different process than men. So most women here, I send to Jeanette Black, and I say, let her see you. She's a dermatologist. She's got to see why you have hair loss, because in most cases for women, it's not strictly testosterone based. It could be from inflammation in the scalp. It could be genetic because their mom always had pore density on their scalp. It could be from an immune issue. It could be from an estrogen issue. It could be from a thyroid issue. So you have to check your hormones and metabolism. You got to check both these things. And if you ask these women who are going through hormonal and metabolic fluctuations with their thyroid hormone, ask one woman who's gone through menopause, who has had these hot flashes and gone through these hormonal cycles with their doctor, trying for years to get their hormone levels in sync. Ask them, if someone were to offer you HGH and testosterone, and they're not an endocrinologist, and it has the potential to do this to you and your hormonal fluctuations, would you take it? And their answer to you would likely be, no, I'm not psychotic. However, this is the world we live in, and everybody is doing HGH and testosterone and whatever. So we are starting a center here called Etern. We're figuring out if it's Etern. I think it's Etern Vitality and Energy, so Eve. And the whole idea here is to get people away from doing caffeine, away from too much coffee, like 9 cups a day, away from HGH, testosterone, and trying to give them natural forms of energy, because everyone's tired every day. So that's the idea that we have over there, and we're going to treat some of these things, hopefully, by getting people away from those and referring them to proper endocrinologists who can really evaluate and tell them if it's safe and tell them the risk of long-term use. And an endocrinologist would probably tell you, hey buddy, I'm giving you testosterone, you're going to lose hair potentially because you have the familial trait, and I'm upping your testosterone, but they don't tell them this. Same thing happens in transgender changes, where a patient who is going from female to male starts to take testosterone, they will start to lose hair. And I've seen female to male transgender patients go completely bald within a matter of 1 year of taking the testosterone. And it doesn't matter to them. They start growing facial hair, which is what they like. Their voice gets a little coarser, which is what they like. So they're getting the changes that they want. Unfortunately, they get the hair loss up top, and some of them have to do hair transplantation. Fortunately, the hairs on the side, where anywhere you have muscle on your scalp, whether it's occipitalis or temporalis muscle, those areas have they're a little less sensitive to androgenetic or androgenic hair loss. So they don't fall out as much when you have testosterone issues. And the last thing someone just brought up is minoxidil. Sorry, I didn't bring this up. Thank you for bringing that up. Minoxidil is a nitric oxide-based medication. Minoxidil, Rogaine is the name that we know it as a brand name, is a solution that comes in a 5% solution, and classically also came in a 2% for women, but that's pretty much useless. The reason they came out with the 2% for women is because women were growing facial hair sometimes when they're using the 5%. But the 2% doesn't really work so well. So minoxidil is a medication that you put on the scalp. It was initially indicated for the crown because it keeps hair in the growth phase longer. It also increases dilation of the area, so there's a little bit better blood supply or we don't know, something like that. It's also a little anti-inflammatory because of that. So it can also be inflammatory. So I take that back. It's both, because it can get someone's scalp red and irritated initially. So but either way, it dilates the area, and you can get a little bit of hair regrowth in the crown from it. And if you're taking it with finasteride as a combination, sometimes it helps this area grow as well. In women, it helps also. And interestingly, if you put it on the eyebrows, it can help. If you put it on incisions for after facelift, it can help. And with the eyebrows, if you put on Rogaine and Latisse in a patient with brow hair loss, they can actually get thickening instead of going and trying to do a hair transplant. I always tell people leave hair transplant as like a last option for brows, because if you don't do it with the right person, it's going to look like pubic hair. Same thing. It all looks like that. It looks like armpit hair, pubic hair. It doesn't look good. The armpit hair is pubic hair, but either way, isn't it? I think. So there are two doctors in LA that are really, really good at brow transplants. It's Dr. Dower and Tim Nevin. And they're both excellent at it. They do really, really fine work, and it looks great. Other doctors, it just looks like they plucked in a bunch of pubic hair. Not so great. So either way, Latisse and Rogaine worked for that. Latisse for the scalp has been studied. There are forms of the prostaglandins that do work a little bit for hair loss on some people, but it's never been proven. So there are solutions that you can buy from the pharmacy that are mixes that do have finasteride. They have Retin-A, because Retin-A will increase the penetration of these medications. 5% minoxidil, 8% minoxidil, 10% minoxidil on some people. And they make all these like a stronger version of Rogaine. And some of them do work really, really well. But sometimes you get headaches because it ends up dropping your blood pressure, and you get headaches from that if you have a blood pressure of 110 or 100. If you use Rogaine, it'll drop it. You'll get headaches from it most likely. Otherwise, there are patients who have skin issues on their scalp, and having the inflammation there, just like eczema, can cause hair loss over time. These are issues that can't be diagnosed very easily. You just notice when someone says, you know what, I started having this inflammatory issue, and my scalp's been itching, and I've had hair loss at the same time. It might be a fungal overgrowth, a flora imbalance. There could be all these different things, but they got to go see a dermatologist like Jeanette Black, who can look at the scalp and say, you know what, I'm a dermatologist and I know hair, and they give you a good option. So let's go through some questions, because I got to leave the office. It's 8:40 and I need to be. So what about product Her that JLo uses? I do not know about her. Not sure. Okay, so no one put actual questions on the Q&A. So we'll go through a couple and blah, blah, blah. And you went to Coachella. Yeah. Hello from Guadalajara. Hello. Did you like Billie Eilish? Didn't go to Billie Eilish. Missed it. Went to Harry Styles. The best one was Big Sean. That guy's amazing. Didn't get to see Stromae, which was my dream to see. Hi from Louisiana. Are there questions? Do you do shadowing for high school students? Not anymore. I have so many doctors visiting me. I have 2 doctors here at a time every day, and it's like rude to patients if I have more people. So I can't unfortunately do that anymore. And fantastic. And my sister didn't insult me too much, so that's good. And okay, well, we'll cut it now. He'll get bored otherwise. Let's see what other questions we got here. PRP, yes. Oral or topical minoxidil. You can't take oral minoxidil, so it's topical. And who's the derm for hair loss? Jeanette Black. Jeanette, Black. She's on Sunset and Doheny. When does my center go live? Etern will go open up probably in hoping August, September. We'll see. We're waiting for our permit. And do you love me? Thank you. Is Morpheus? Wrong talk. How often is nanofat injection needed? We do that about once a year. So the PRP, when you do it effectively, high concentration PRP with ACell, with exosome, or with nanofat, we do it about once a year. You can do it more than once a year, but once a year is when most people start to see the hair loss again. And the way we gauge our success is not always super scientific. Patients go home after the treatment, and about a month to 2 months, for about 2 weeks, they get shedding because you stressed out their hair. Hopefully you did it atraumatically because you don't want to lose too much hair. At 2 months, they come back and they say, you know what? My hair loss stopped. How do you know your hair loss stopped? Well, I used to have a bunch on my pillow. It's not there anymore. I used to have a bunch out in the shower. It's not happening anymore. Is that science? Is that evidence-based medicine? No. But 90% of patients will say this. That's enough for me. 30% of patients, I'll take their photo and they will have a visible change from before to after without other interventions. And that change, I don't know how long it lasts, but the hair loss usually resumes at about a year, so you repeat it once a year. That's the way we do it. Other clinics do it differently. They have different methods, techniques. They all work differently. Best treatment for dandruff, I do not know, but I do know, but there's like a million different things that you can do. And we'll leave it at that. Okay, so I will post this in case anybody cares. And don't be offended if you're a doctor and you prescribe HGH and testosterone and have no true board certification, and I said something negative about you. I apologize. I just think that hormones are very, very difficult to balance, and I would be scared if someone touched my hormones who didn't have a board certification or training. There are internists who do tons of thyroid changes, but they know how hard it is, and they will tell you too. So the internists are well trained, and they don't generally do it. So it's usually a general practitioner who didn't go through training, and then they go and they think nothing harmful can happen. So just my hot take. I never say that, but it is my hot take. Not evidence-based anything I said, so don't hold me to it.